Hello, my name is Dr. Anand Narnavre. I am a pediatrician in Pune, and today's topic would be growth and development in pediatrics. So, what do you mean by growth and development? By definition, growth is the increase in the physical measurement of the body, example, weight, height, head circumference, etc. Okay, and development would be it is a process by which the child learns a new skill and gradually becomes more capable physically, mentally, emotionally, and socially. So these are two different aspects of the pediatric patients or pediatric population. Okay, so as a pediatrician, we need to be thorough with the growth and development of in pediatrics. Okay, so what are the normal parameters at birth for a term baby who has crossed 36 weeks of gestation? These are the normal parameters. So uh, at birth the weight should be at least between 2.5 to 4.2. Okay, so this is a normal range. If it is less than 2.5, then it is considered as low birth weight, and if it is more than 4.2, it is considered as large. Okay, height is approximately around 50 centimeters at birth. If it is less than 46, it would be considered as less, and if it is more than 54 centimeter, it is considered as high. Okay, on an average it is around 50 centimeters, and the head circumference is approximately around 35 centimeters. The range would be 32 to 36, and if it is less than 32 or more than 36, it is abnormal. Okay, so how does the baby grows from at birth till further in his life? So for an approximate guess, we can consider the baby generally doubles its weight by 5 months and triples its birth weight by around 1 year, and four times its birth weight by at approximately 2 years of age. But that is a very rough estimate. Okay, so um, we should actually use a growth chart for assessment of the growth. Okay, so this is just a rough idea. Okay, these are the values we should memorize actually. So at birth the average height is around or length is around 50 centimeters, and at 1 year of age it becomes 75, that is increased by 25 centimeter approximately, and at 2 years of age it becomes 90 centimeters. Okay, and head circumference at birth is around 35 centimeters, which increases by approximately by 10 centimeter in first year, and in the next year it increases just by 2 centimeters, so it becomes 47 centimeters. Okay, so these are the approximate values. So the best way to assess a growth is by using a growth chart. So what are the growth charts available in for us? So there are CDC growth charts, WHO growth charts, and IIP growth charts. So in this, the best option would be to go with the WHO growth charts, because WHO growth charts are universal growth charts. Okay, and in any race or any country, you can use this chart, and these are standardized. Okay, so this is an example of a WHO growth chart for boys, where you can see it is marked from birth till 5 years of age. Okay, and here the this black line is the upper limit of the normal, and this lower black line is the lower limit. Okay, of the normal weight, and green line is the average weight of the baby. Okay, and um, anything beyond this black lines, either in this region or this region, would be abnormal. Okay, so this is the green line is the average line. So this chart is from birth to 5 years, but there are various other charts available on the WHO site, official site, where you can download from the charts from birth to 6 months, or birth to 2 years, and also 2 to 5 years, birth to 5 years, and 5 to 10 years. So there are various charts. As per your requirement, we can use the charts. So this is one of the example. So this is the height chart. As you can see, at birth the average height is around, or average length is around 50 centimeters, and um, the maximum growth it occurs, that is the steep growth that which occurs is during the first year of the life. Okay, and at 1 year it is around approximately around 75 to 76 centimeters. Okay, again, the this black upper line is the upper limit, and the this lower black line is the lower limit. Okay, anything beyond this would be considered abnormal. Okay, here abnormally high, and here in this region abnormally low. Okay, so similarly these are the charts for the girls. So the parameters for girls are slightly lower than the boys. These are the CDC charts in which they have incorporated the head circumference also in this, and this chart is from birth to 24 months. Okay, and these are for boys. Okay, so up to 2 years, these are the charts. So there are various charts. This is the chart for the girls. Okay, from again birth to 24 months. Okay, and in this head circumference, weight, and also uh, weight for length is also. Okay, so these are the IAP growth charts. Okay, which are from birth to 18 years of age. Okay, so here we have we can write the father's height, mother's height, and also we can calculate the target height, and also at 18 years of age how would be what is the target age, target height of the child, that also we can project here. So what are the patterns of the growth in a normal child? So during the first 12 months, the height velocity is maximum. So you can see here 24 centimeters per year. So at birth, as you know, the height of or the length of the baby was around 50 centimeters. So in first year, it is around 75 centimeters. So in 1 year, the baby has gained 24 centimeters. So that is highest. Next year, that is from 1 to 2 years of age, the baby's height grows only by 10 centimeters. And then at 2 to 3 years of age, it is 8 centimeters. So gradually the growth velocity goes down. So maximum it is in the first year of life. Okay, and during the childhood, that is after 1 year of age, after 3 years of age, so you can see 6 centimeters per year. Okay, and the slowly decelerates before the pubertal onset, and height typically does not cross the percentile lines. Okay, and what happens during the adolescent, that is this again there is a growth spurt during the pubertal age. Okay, which accounts for around 15% of the adult height. Okay, so peak height velocity is around 8 centimeters per year in adolescent, that is from more than 10 years of age, and boys is around 10 centimeters per year. Okay, so there are two growth spurts, mainly during the infancy first year and also during the adolescence. So this is a body mass index, that is weight upon height, that is weight in kg upon height in meters square. So you can see here, so growth velocity initially is high, and gradually the BMI decreases, that is around 5 years. You can see 5, 6, 7 years the BMI is low, that is weight for height would be less compared to. So here the baby would look chubbier in the first 2 to 3 years. You can see here, as the weight for height is high or BMI is high, but as the child grows and it goes into the adolescent age, you can see the BMI again increases. So gradually it increases. So weight for height would be better here after 7 or 8 years of age. So similarly for the girls. Okay, what are the so we have discussed what is the normal weight at birth, what is the normal length of the child at birth, and what is the normal head circumference, and how the baby grows. So the growth charts are the best method to assess the growth of the child. Okay, and in that also, if you use any chart you can use, but WHO are user friendly, and also standardized growth charts. Others are also there, but charting in the WHO growth charts is little easier. Okay, so now we can see, we will discuss the common causes of decreased growth and short stature. Okay, so if we find any child who is having decreased weight or decreased height, so how will we go further for what will be the causes for the decreased growth or short stature? Okay, so it is divided into various parts like variation of normal, either because of some nutritional or gastrointestinal conditions or genetic conditions, some skeletal dysplasias and endocrine conditions also. Okay, so what is the variation of normal? So first is the familial short stature. So what is this familial short stature? So familial short stature is the parents, both the mother and the father, are short. So that is why the child is also short. So that is called as familial short stature. And what is constitutional delay? So constitutional delay is delay in the puberty. Okay, delayed puberty, which is genetic. Okay, and in this. The child will be initially on the lower centiles, and once the child attains the puberty, it will as an adult, when he becomes an adult, so he will regain, he will achieve his target height. Okay, and he won't be most likely a short child in the adulthood. This is called as constitutional delay. But in the familial short stature, the child will be short, okay, as per the parents heights. Okay, so and other cause is also one of the causes, delayed puberty. That could be because of various reasons. Okay, what is the second group? That is nutritional and gastrointestinal conditions like malnutrition, okay, celiac disease, okay, and inflammatory bowel disease. In this, the nutrition is affected of the child, and hence the child will be having decreased growth or short stature. Okay, there are certain genetic conditions like Turner syndrome, Prader-Willi syndrome, 22q deletion, and trisomy 21, that is Down syndrome, which has lower weight and lower height, okay, from the normal population. Skeletal dysplasias like achondroplasia, SHOX, haploinsufficiency, osteogenesis imperfecta. So these all causes short stature. Okay, endocrine conditions like hypothyroidism, growth hormone deficiency, poorly controlled diabetes mellitus, poorly controlled diabetes insipidus, metabolic bone disease like rickets and phosphatasia, and glucocorticoid excess. Okay, so all these conditions can also lead to decreased growth and short stature. There are other causes like psychosocial causes like renal conditions like RTAs and nephrotic syndrome, medications like glucocorticoids, inappropriate sex steroid exposure, and antiepileptic medications may also hamper the growth of the child. So what are the common causes of decreased growth and short stature? So here in this chart, we can see there are four common causes have been discussed. So first is the postnatal onset pathological short stature. Second is constitutional growth delay. Third is the familial short stature, and last is the prenatal onset of pathologic short stature. So here the dotted line, that is the first one, that is a postnatal onset of pathologic short stature. So here you can see, so here what happens, this is the birth and this is the 24 months. So first 2 years the child is on the higher normal range. So okay, so this green belt, which we can see a darker shade, okay, this is the normal growth pattern. Okay, and this yellow line is the average. Okay, so it is the average height of the child. Okay, so here you can see the dotted lines here, that is the postnatal onset of pathological. The child is on the higher side, but once he crosses around 8 years or 9 years, so you can see he has the growth faltering, and he is crossing the centiles. Now he must be here around 97 centile, and now he has crossed the 50th centile, and also now he is crossing the third centile. Okay, here, so he is falling out of the normal range. So this is, so here at around 9 years, you can see at around 9 years the child has started faltering his height. Okay, so this is the postnatal pathologic short stature. The causes could be anything like malnutrition or other causes which we have discussed earlier. Okay, the second cause is constitutional growth delay. So here this blue color line, okay, here we can see up to 3 months, 6 months, the baby is following the 50th centile, and then the baby is starting to falter. He is going on the lower centiles, and around 8 years he is still on the lower side, okay, around third centile, okay, on the lower side. And now at around say 15, 16, so the puberty occurs and the child has a growth spurt, and at around 18 years of age he has attained his target height. Okay, so this pattern is of constitutional growth delay. So that is, there is a delay in the puberty. Okay, but ultimately at around 18 years he will reach the target height, so he won't be short in the adulthood. Okay, the third is the familial short stature. So both the parents are short, the father and the mother both are short. So here they are lying around less than third centile. Okay, so and here also at around 8, 9, and ultimately at around 18 years you can see the child is below the normal range. Okay. Hmm? So the familial short stature, both the parents would be short. Okay, and what is the last one? That is prenatal onset of pathologic short stature. So like a small preterm baby, like the baby was say 1 kg, you know? So he was small at birth only, so he will be behind the normal range throughout his life, you can see here. Okay. Hmm? So here this is called as a prenatal onset. Already the baby was small, okay, before at birth only he was small. So ultimately also the baby has not attained is on the lower side, okay, below the normal range. So these are the 4 common causes of short stature, that is postnatal onset, constitutional delay, familial short stature, and prenatal onset. So one of the commonest is the constitutional and also the familiar. Okay, in these also, so these two are the more common, the familial short stature and the constitutional one. So what are the causes of increased growth or tall stature? Okay, so there are causes for low height and weight, and also causes for increased growth or tall stature. So what could be the causes? Again, constitutional tall stature, that is early puberty. Okay, and familial tall stature, that both the parents are tall, so genetically the child's target height or the target range would be on the higher side. Okay, and endocrine conditions, like there could be some growth hormone excess, precocious puberty, congenital adrenal hyperplasia, obesity. Okay, so these are all causes of the increased growth or tall stature. Okay, and genetic conditions like Marfan syndrome, Klinefelter syndrome, Sotos syndrome, this syndrome also has very high height. Now we are going to discuss about the development part. Okay, so what is development? That is, the child will achieve certain skills and will be independent, okay, physically, and will attain certain skills, and uh, as per the age the child will attain the milestones. Okay, so there are 4 categories of the milestone mainly. Okay, gross motor, fine motor. First is gross motor, second is fine motor, third is the language, fourth is the cognitive skills. So we'll discuss one by one. So what is gross motor? Gross motor is motor skills which are like walking, running, jumping, skipping, okay, standing. Okay, these are the gross motor skills. And what are the um, fine skills? Like holding a pen, okay, holding a ball, throwing the ball, okay, feeding himself. Okay, so these are the fine skills which are basically of the fingers and the hands. Okay, third is your communication and language. So the baby starts speaking. Initially the only cooing is there, then monosyllables, then bisyllables, then few words, and then sentences, so and so on. And cognitive, so how the baby interprets and um, uh, interprets the surrounding and communicates with the surrounding and plays with the surrounding are the cognitive milestones. First we'll discuss the gross motor. So baby holds the head steady while sitting. It is around 2 months of age. Okay, and it allows more visual interaction, as the baby can hold the head properly, so he can turn the head and allows more visual interaction. Okay. If we pull to sit with, there should be no head lag at 3 months of age. So the neck muscle tone should increase. Okay. If there is a head lag, then there is a delay delay in the attaining the muscle tone. Okay. Third one is brings the hand together in the midline. Okay. So this is of the self discovery of the hands. Okay. And what is asymmetric tonic neck reflex, or we also called as ATNR. So what is ATNR? So if the child has turns the head suddenly towards the right side, so what will happen is same side arm would extend. So that helps the baby to not to roll over, and it is a protective reflex so that the baby doesn't fall. Okay, on whatever surface he is. If suddenly there is a neck movement on the on the side, on say right side, so his right hand will extend and it will block the baby's rollover. Okay, so what happens at 4 months? The ATNR is gone. Okay, so what happens? ATNR, if it disappears, only then the baby can roll over. That is from prone to supine position and from supine to prone position. Okay, so this reflex disappearance is also important for the next milestones to be achieved. Okay, what is the next milestone? That is sits without support. So before that, at around 5 months of age, there is a sitting with support also. So what is the sitting with support? The baby will be placing his hands on his thighs or the floor and will be sitting, and if we remove that support, the baby will fall. So this is called as sitting with support. Okay, and at around 6 to 7 months of age, the baby will be sitting without support. So if we the baby will not take support of his own thighs or the ground, and can turn also. So this happens around 6 to 8 months of age. So baby can be able to turn around also. Okay. Rollover, that is rollbacks to the stomach. Okay. So that is around 6.5 months. So first, generally, baby learns from supine to prone position, and then it learns from prone to supine position. Okay. Baby starts walking at around 1 year of age. That is his first birthday. The baby will start walking. Okay. Before that, there is another milestone at around 11 months, where the baby will hold the objects like a chair or a table or a bench, and it can move with the help of the table or the chair. So that is called as cruising. So that comes around 11 months, and here at around 1 year, near about his first birthday, the child will start walking. Okay, and runs around 16 months. Okay, so here at around 16 months, the child runs around, and there is a risk of fall also. So in this age, around say after 1 year, 1 to 1.5 years, the child is just learning to run. So here the incidences of fall and head injuries are more. Okay, so next group is around the next domain is fine motor skills. So what is the fine motor skill? So especially the hands. Okay, so fine motor skills, the grasp the rattle at around 3.5 months. Okay, so at birth, the baby's fists are generally closed. Okay, and it opens his hands at around 2 months, and then it can hold the objects. Okay, at around 4 months, it reaches for the objects. Okay, that is because of the visuomotor coordination. Palmar grasp is gone. What is palmar grasp? So whenever the baby, if you touch the baby's palmar surface, it suddenly will grasp the whatever thing is there in the hand. So you must have seen in during the birth also, many times the obstetrician, when the baby is being taken out by C-section or during the normal delivery also, the baby clenches the whatever either umbilical cord or the surgeon's hand or fingers also. So that is called as a palmar grasp. Okay, so for the to reach to hold the objects, so the palmar grasp has to be lost. Only then the baby is able to open the hands and reach for the objects and hold the objects. Okay, so around 6 months or 5.5 months, you can see the baby can transfer the objects hand to hand. So if it is from like say this pen, so the baby can transfer the objects. It is around 6 months. Okay, so thumb finger grasp, that is around 8 months. So this is the thumb finger grasp, that is around 8 or 9 months of age. So this is called as pincer grasp. Okay, so pincer grasp actually allows the baby to pick up and hold the smaller objects. Okay, like a pea or a grain. Okay, so it is very essential to tell the parents that because the child is now uh, 9 months or 9 months around, so he is able to pick up the smaller things and also may feed put it in the mouth, so it may cause some foreign body aspirations situation. So that is why it is important to guide the parents at around 8 9 months, that now he can hold the smaller objects also. Initially he will be able to uh, hold the bigger objects with both the hands. Now he can because of the pincer grasp, now he can pick up the smaller objects also. Okay, so at around 1 year the baby can turn the pages of the book. Okay, scribbles at around 13 months, builds a tower of cubes at around 15 months, and builds a tower of 6 cubes around 22 months. Okay, so what are the communication or the language skills? So you can see at around 2 months the baby starts cooing, that is just makes a cooing sound, that ooh, like this. Okay, so this is around 2 months of age. Okay, and syllabic babble, that is ma like this, or ba. Okay, so this is the monosyllable babble. Okay, that occurs around 6 months of age. Okay, and uh, inhibits to know at around 7 months. So if you say no to a child who is around 7 months, so the baby might understand that this what does no means. Okay, okay, and follows the one step command with gesture, follows one step command without a gesture. Okay, this is at around 7 and 10 months of age. Okay, like for example, one step command without a gesture, like if you say give it to me, okay, only you say and you don't show the hands. Okay, so this is they can follow that, they can understand the command. And like if you make your hand forward and baby is playing with a toy and you ask for it, so this is a non-verbal communication and the baby will be given at around 7 months. Okay, um, at around 10 months the baby can say mama, dada. Okay, so these are bisyllables. Okay, and points to the objects at around 10 months, speaks the first real word at around 1 year, 4 to 6 words around 15 months, 10 to 15 words at around 18 months, and two word sentences like mommy shoe at around 19 months. Okay, so you can remember at as like 9 months the baby can say bye bye or baba, that is bisyllables, and also can wave bye bye. Okay, so at 9 months you can remember bisyllables bye bye. Okay, and next domain is the cognitive development. Okay, so what so at around 2 months the baby stares momentarily at a spot where the object disappeared. So if you bring a object near the baby is focusing on that object, and if you suddenly remove it, so baby will be still staring at the same spot. Okay, so this is at around 2 months of age. Stares at the owned hands at around 4 months of age. Okay, uncovers the toy at around 8 months of age. So whenever the any toy is hidden under a cloth or something, so the baby is able to uncover it and find it. Okay. um, Egocentric symbolic play, like example, pretends to drink from the cup, so he can mimic, even though if it is not there, water, he can still mimic. So that is around 1 year of age. Uses the stick to reach a toy, so this is a use of objects to help himself. Okay. And pretend to play with the dolls at around 18 months. Okay. So these are the cognitive milestone. So after 2 years of age, you can see the child is able to run well, walks upstairs and downstairs one step at a time, opens the door and climbs the furniture and jumps. Adaptive or fine motor things. Okay. The child is able to make tower of 7 cubes, scribbles in circular pattern, imitates horizontal strokes and folds paper once imitatively. Okay. So you can remember the fine motor skill, like he can scribble in a circular pattern at around 2 years of age. Okay. Okay. And for 2 years of age, he can put 3 words together. Okay, like give me water. Okay. So at 2 years of age, the baby can be, there is a 3 word sentences he can form. And social milestone like handles the spoon well, and often tells about immediate experiences, helps to undress, listens to the stories when shown pictures. Okay, 2 years of age. So around 2.5 years of age, the child can goes upstairs with alternating feet. Okay. And 2.5 years, the child also can make towers of nine cubes and make vertical or horizontal strokes. Okay. And the language, you can the refers to self by pronoun I. Okay. Knows the full name. So around 2.5 years, the baby knows his or her own name. Okay. And social, he can helps put things away and pretends in play. At around 3 years of age, the baby can ride a tricycle, stands momentarily for on 1 foot, and can make a tower of 10 cubes. Okay. And knows the age and the gender, counts 3 objects. So at 3 years, you can see there are a lot of milestones which are achieved. Like the baby can ride a tricycle, can knows his age, knows his sex, whether he is a boy or a girl, knows knows his own name. Okay. And the child can play simple games. Okay. And helps in dressing, and also washes the hands. That are, it is around 3 years of age. Okay. So what happens at 4 years? So hops on 1 foot. Okay. Throws the ball overhand, uses scissors to cut out pictures. Okay. Copies the bridge from the model, imitate construction gate of 5 cubes. Okay. Draws a man with 2 to 4 parts besides a head, identifies longer of 2 lines, counts 4 pennies accurately, tells a story. So 4 years, the child can tell a story. And social, plays with several children, beginning of social interaction and role playing. Goes to toilet alone. So at 4 years, the child should go toilet alone. Okay. And 60 months, that is around 5 years, the child can skip. So what is skipping? So skipping and hopping. So what is the difference? So at 4 years, the child can hop. So that is on the one leg. Okay. And skipping is on the two legs. So the skipping rope, so both the feet should be off ground. So that is called as skipping. And only the child is jumping on 1 foot, that is called as hopping. So hopping comes earlier than skipping. Okay. Even though if we might assume that hopping is difficult, but hopping comes earlier and skipping comes afterwards. And the child is able to draw a triangle, can name 4 colors, and dresses and undresses himself. At around 5 years, the child is able to dresses and undresses also, and it engages in the domestic role playing. So these are the milestones in the 4 domains: the gross motor, fine motor, language, and the cognitive one. So if we should know the grossly the roughly, we should know what are the important milestones, like head holding should be attained, maximum by around 4 months. Okay, that it should be complete. The child should be able to walk. Generally, it is around 1 year. Okay, starts to run at around say 16 months or 18 months. Okay, waves bye at around 9 months. Okay, bisyllables at around 9 months. Okay, can tell his name by around 2.5 to 3 years. Okay, knows his gender, his age, and can tell at around 4 years, can tell a story. Okay, and is able to hop on one leg. Okay, and at around 5 years, the child can go to the toilet alone. Can identify more than 4 to 5 colors. Okay, and helps in the domestic role play. Okay, so these are the important milestones which we should roughly should know. And if we find that the child is not attained these important milestones as per the age, so there should be proper investigation and proper history taking and investigation to find out the cause of the delay. Okay, so what are the red flag in the developmental screening and surveillance? Okay, so what is the red flag? Red flags matlab means like if you find these signs in any child, so you should escalate further. Okay, so what are the positive indicators? So there are positive and also negative indicators in the red flags. So positive indicators are something which is there. If you find it, if you find these findings, so then these are the red flag signs. And if there is an absence of something, so that is a negative indicators. So we are discussing about the positive indicators initially. So presence of any of the following, like loss of any developmental skill at any age, like suppose the child was able to sit without support, and now after say 1 or 2 months, the parents are complaining that he was able to sit without support now, but now he is again not able to sit without support. So a loss of any attained milestone, that's a red flag sign. Okay, but what is the another thing? That is parental or professional concern about vision fixing or following an object and confirmed visual impairment at any age. Okay, so what if the parents tell you that the child is not able to follow the objects whenever the child is being handled at home? Okay, and the parents are telling you that the child is not able to, we feel that the child's vision is not appropriate, so we need to escalate. We should refer to the pediatric ophthalmologist. Hearing loss at any age, simultaneous referral for expert audiology. So hearing screening has been universal and mandatory for every child now. So at birth we do the auto acoustic emission, that is the OAE screening. So and confirmatory hearings test is the BERA, brain evoked response audiometry, which is done around 3 months of age. So if at any age, if you find that the child is not responding to the sound, so we should escalate the case, and we should refer the child to the assessment, hearing assessment. Okay, and persistently low muscle tone or floppiness. So that if you find the tone to be low and there is a floppiness, so we should this is a red flag sign. Okay, no speech at 18 months, especially if the child does not try to communicate by other means such as gestures. So there is a verbal communication and a non-verbal communication. So at around 18 months, if the child is not able to, there is no speech, and if the child is also not pointing towards any thing, that is non-verbal communication is also affected, then it is a red flag sign. As you know, it could be early sign of autism. Okay, asymmetry of movements or other features suggestive of cerebral palsy, such as increased muscle tone. Okay, if you find asymmetry of the movements, that the child is only moving the one side of the body, only moving his right or right hand or right leg, and not comparatively, if the parents tell you that the child is not using the other side, so that's a red flag sign. Toe walking. Okay, So toe walking tells you the hypertonicity of the lower limbs. Okay, so in a cerebral palsy spastic CP especially, this persistent toe walking is there. Complex disabilities. Okay, if you find a complex disabilities, again it's a red flag sign. Head circumference above the 99.6 centile or below the 0.4 centile. So that is above the 3 standard deviation. Okay, or the 3 standard deviation in the growth chart. So if you find that the head circumference is too large or too low, okay, so we need to investigate it and also compare it with the parental head circumference, so that it should not be a familial one. Okay, because high head circumference will tell you about hydrocephalus, and low head circumference will tell you about microcephaly or decreased brain growth. Okay, and assessing clinician who is uncertain about any aspect of assessment but thinks that development may be disorder. Okay, if a clinician or a pediatrician who is examining the child, if he feels that the child is not up to the and has not attained the milestones, or if he doesn't feel that the child is normal or has attained the milestones he should have attained, so even that is a red flag sign. So what are the negative indicators? So these are the activities that the child cannot do. So if the child sit unsupported, if the child is not able to sit by unsupported by 1 year of age, that is 12 months, so that is a red flag sign. So he should be able to sit without support by 1 year of age. Walk by 18 months. Generally the babies, they start walking at around 1 year of age, that is around 11 months, 12 months, 13 months, 15 months. Maximum what we can wait for is around 18 months. Okay, so if the child is not able to walk by 18 months, so that's a red flag sign. Okay, walk other than on tiptoes. So only toe walking is there, so that again represent the hypertonicity of the lower limbs. And if the child is not able to run by around 2.5 years, so as we discussed earlier, that the child should be able to run by 18 months of age, that is 1.5 years. But if he or she is not able to run by 2.5 years, it's a red flag sign. Hold object placed in hand by 5 months. Okay, at around 5 months, the baby is not able to hold the object. Okay, so that is the child should have a bidextrous approach at around 5 months. And if the baby is not able to hold the object, that is his palmar grasp is still intact and it's not opening his hand, so that is a red flag sign. Reach for the objects by 6 months. Okay, the child, whenever the object is shown, the child should be able to reach for the objects, that is around 6 months. And if it is not there, and it's a red flag sign. Okay, point at objects to share interest with others by 2 years. If the child is not able to communicate even non-verbally, okay, it's showing a pointing at a toy or whatever the child wants, if he is not able to communicate either verbally or non-verbally by 2 years of age, and is not showing interest in the with others, so that is an early sign of autism, so that is a red flag sign. So what are the screening standardized tools for general developmental screening? So as we discussed, the to assess the growth, we need a growth charts. So similarly, these are the developmental screening charts. Okay, so there are various screening tests available. Okay, like ages and stages questionnaire, parents evaluation of developmental status, parents evaluation of developmental status with developmental milestones. So you can see it hardly takes around 5 to 10 minutes of time. Okay, survey of well-being. Okay, of a young child. Okay, ages and stages questionnaire. Okay, a brief infant toddlers social economic assessment, that is from 1 year to 3 years. and pediatric symptom checklist, strengths and difficulties questionnaire. So there are various screening tests which are available for various age groups. Okay, so for autism, there is a specific chart like this is called as modified checklist for autism in toddlers. Okay, so this we can carry out on a child who is around 16 months to 48 months, that is around 4 years of age. Okay, so this is called as MChat. Okay, so this is for the screening test for toddlers, that is around 1.5 years to 4 years of age, and there is a questionnaire and you have to give the score, and at the end of the screening you can be able to assess the child whether it is a high risk for autism or not. So one of the simplest developmental screening tool is the Trivandrum developmental screening. So here you can see from birth to 3 years of age, you can see the the milestones which are there. There is a range of milestones. So what we can do is we can see, suppose for example a child is around 1 year of age, so we will put a scale here at around 1 year of age, and we will see which all milestone the 1 year line is crossing. So like the child should be able to here at 1 year, so pat a cake, walks with help. So around 1 year the child should be able to walk and should be able to throw a ball. Okay, and is able to walk alone. Okay, so whatever the range of the milestones the 1 year line is crossing, the child should be able to achieve those. Okay, or he or she will achieve in few months, but whatever the milestones which are on the left side of the child's age, he should be able to he should have achieved that. So this is a simple and efficient and very uh, frequently used developmental screening tool. Okay, so this chart is from 3 years to 6 years. So at any age, at any given age, any all the milestones which are on the left side of the age line, the child should have achieved that, and whatever the child is crossing those milestones, he is in the process of achieving those, and there is a range for each and every milestone. So this is a very easy and frequently used developmental screening chart. So now we come to the a term called failure to thrive. So what is this failure to thrive? So as we have discussed about growth and development, so failure to thrive is classically been term used to describe the children who are not growing as expected. So this this you can assess with a growth chart. Okay, and the child should achieve a certain weight and height as per the age, and if the child is not able to do it because of the various reason, so we call it as failure to thrive. Okay, there can be various reasons for it. Okay, so here first we need to assess with the anthropometry, that is measuring the weight, height, skin fold, mid upper arm circumference. Okay, so mid upper arm circumference is also one of a screening tool to assess the malnutrition. If it is the mid upper arm circumference, if it is less than 12.5 centimeters, so it is considered malnourished. 12.5 to 13.5 is considered borderline, and more than 13.5 centimeters is normal mid upper arm circumference. It is around for the children less than 5 years of age. Okay, so you can use the WHO or the CDC charts for this. Okay, So what could be the causes? So some there are various causes, like it could be non-illness related, like behavioral, socio-economic, or environmental. So what is behavioral? Okay, so what is the child is a fussy eater and is not able to he has been not been introduced to the complementary food at proper age, and a variety of foods has not been introduced. So that is a behavioral issue. And socio-economic or environmental is there is a food supply is less. If the child is from a lower socio-economic strata, or if there is an environmental, that is shortage of food, okay, in the surrounding, so there it also can causes the malnutrition. One of the other common causes are the illness related, like the child could be either because of the acute illness or because of the chronic illness. So when you must have seen, whenever the child is having infections or any illness, so the child first thing is they stop eating. So if the illness is say of say 10 days or 15 days, sometimes even after the symptoms recover, the appetite doesn't improve for say months also. So that causes a malnutrition. And chronic illnesses like cystic fibrosis or chronic lung disease or cancer, because of the high metabolic rate and because of the high demand, so it causes a malnutrition and ultimately results in failure to thrive. The last mechanism is the inflammation. Okay, so we'll discuss the non-illness and the illness related. Okay, so what happens is so anorexia, so this is a behavioral thing. Okay, a socio-economic, iatrogenic feeding interruptions and intolerance. Okay, so these all causes decrease intake. So if the calories going in are less, so obviously the child will not grow properly, and it will cause to the child to failure to thrive. What are the other causes? The malabsorption, the nutrient loss, the hypermetabolism. So if the child is having some malabsorption syndrome, okay, either fat malabsorption or protein malabsorption, or even carbohydrate malabsorption, so it will cause a lot of the intake is normal, but the absorption is not there. Okay, so it will cause the malnutrition, nutrient loss. Okay, and hypermetabolism. They like in cancer. So there is a high energy expenditure. Okay, or any inflammatory condition also, it causes the high nutrient requirement, and if comparatively if the this metabolism is higher, so the child will cause it will cause the child to lose the weight, or um, it will cause to malnutrition and ultimately to failure to thrive. Okay, so malnutrition where the intake is, if it is less than the requirement, and energy or protein imbalance and micronutrient deficiencies, this all leads to the loss of lean body mass, muscle weakness, developmental or intellectual delay, infections, immune dysfunction, delayed wound healing, and prolonged hospital stay. So this chart actually explains everything regarding the failure to thrive, the causes and the mechanism, and the outcomes also. Okay, so if the intake is less, so that will definitely cause malnutrition. But if the requirement is high, like in malabsorption syndrome, nutrient loss, or hypermetabolism, in conditions like infections or malignancy, so there could be malnutrition. Okay, so how to approach to malnutrition based on signs and symptoms? So what are symptoms and signs you can see in a child? So you have to take a thorough history and a physical examination of a child of failure to thrive. And if the child gives you say history of say the mother tells you that the child is spitting, vomiting, and food refusal, so that the causes could be gastroesophageal reflux, chronic tonsillitis, food allergies, okay, eosinophilic esophagitis. If the child is having some diarrhea or fatty stools, it could cause malabsorption, intestinal parasites, milk protein intolerance, pancreatic insufficiencies, celiac disease, immunodeficiency, inflammatory bowel disease. Snoring, mouth breathing, enlarged tonsils. Okay, this can be because of adenoid hypertrophy and obstructive sleep apnea. If you find a recurrent wheezing or pulmonary infection, so it could be because of asthma, aspirations, food allergies, cystic fibrosis, and immunodeficiency. If the child is having recurrent infections, the child could have some HIV positive or congenital primary immunodeficiency syndrome diseases and anatomic defects. Travel to or from countries of the parasitic or bacterial infections of the gastrointestinal tract can be suspected. Uh, so, what are the percentage of the causes of failure to thrive? So, you can see psychosocial is around one of the highest. So, it is around up to 50% or more psychosocial. So, what is the history would be vague, inconsistent feeding history, history of bottle propping, okay, and you don't have any soft neurological, none or may have soft neurological signs, okay. What are the CNS causes? The CNS causes are approximately 13% of the total failure to thrive, and it may the history would be of poor feeding, gross developmental delay, and vomiting, grossly abnormal neurologic findings. You can see if the child is having some CNS abnormalities like frequent gross abnormalities in the EEG, MRI scan, and gross abnormal tests of the neuromuscular function. What are the gastrointestinal causes? These account for around 10% of the total causes of failure to thrive. Okay, and chronic vomiting. The symptoms would be chronic vomiting, diarrhea, abnormal stools, crying with feeding, nocturnal cough, and snoring. The symptom-specific physical findings would be often negative, may have abdominal distension. So you can see abnormal barium swallow test and also abnormal stool findings. Okay, cardiac causes are around 9%. So there would be slow feeding dyspnea, and diaphoresis with feeding restlessness and diaphoresis during sleep also. Okay, so often a cyanotic or have signs of congestive cardiac failure. So this could be you can find on the CVS examination. The test abnormal would be an abnormal echocardiogram, ECG, catheterization findings. Genetic causes are also there for failure to thrive, that which accounts for around 8%. May have positive family history or a history of developmental delay. Okay, and often have face is typical of syndrome, skeletal abnormalities, neurological abnormalities, and visceromegaly. Okay, may have typical radiographic findings, chromosomal abnormalities, abnormal metabolic screens like Down syndrome, Turner syndrome, etc. Pulmonary causes are around only 3.5%. Chronic or recurrent dyspnea with feeding and tachypnea. Grossly abnormal chest examination findings. You can see abnormal chest radiographs. Renal causes are this account for 3.5%, which may be negative or may have history of polyuria. The physical findings are often negative, may have flank masses, okay, and abnormal urine analysis, frequently elevated BU and creatinine, and signs of renal diseases. Okay, the endocrine causes around 3.5% with hypothyroidism, constipation, decreased level of activity, diabetes, polyuria, polydipsia. So with hypothyroidism, you will find that there is no wasting but mottling. Umbilical hernias are there, open posterior fontanelle. With diabetes, you often specific abnormality but may have signs of dehydration and ketotic breath and hyperipnea. Hypopituitarism and isolated growth hormone deficiency, growth normal until 9 months or later and then plateaus but normal weight for height, delayed tooth eruption. So you can find the decreased T4, increased TSH, glucoseuria, hyperglycemia in diabetes, abnormal pituitary functions, okay, in growth hormone deficiencies. We can quickly summarize. So mostly the most important cause is psychosocial, and the next is CNS, third is gastrointestinal, cardiac is around 10%, genetic 8%, pulmonary, renal, and endocrine around 3.5% each. So how do we treat failure to thrive? So as we have discussed, there are various reasons, systemic causes, psychosocial causes, which we need to investigate, see for the history and the physical science of the cause of the failure to thrive, and accordingly we have to treat it. So while investigation, we should start with uh, we should start with the nutrition of the child while investigating. Okay, while an illness related etiology of malnutrition is being investigated, caloric supplementation should occur simultaneously. So treatment should begin. First of all, once you find out or you are during the process of finding the cause, the caloric requirement, that is the appropriate calories as per the weight and the age of the child, should be started. Both medical workup and the initiation of supplemental oral feed should occur in the outpatient setting with close follow-up, because malnutrition affects each and every organ of your body, and we have to start the treatment early, while before the investigation. Even we are starting the investigation, but along with that we should start with the treatment also. Consider including a speech therapist for suck and swallow evaluation if the history suggests difficulty with the oral feeds. If there is difficulty in suck and swallow, so we can uh, you know involve a speech therapist to see for any problems with the suck and swallow evaluation. If the child has not responded after 2 to 3 months of outpatient, then consider hospitalization. If you are treating the child with failure to thrive on a outpatient basis, so if there is no response in after 2 to 3 months of your outpatient treatment, so you should consider hospitalization. Okay, for nasogastric tube feeding, for the diagnostic and lab investigations, assessment and observed implementation of adequate nutrition, and evaluation of the parent child feeding interaction. Okay, you can also observe the child when the child is being admitted, how the parent and child feeding interaction also you can observe, and other lab and diagnostic things, and also for nasogastric feeding. So additional indications for hospitalization include moderate and severe malnutrition, since the potential for refeeding syndrome requires close monitoring. So there is something called as refeeding syndrome. So when the child is malnourished for a chronic period, so we have to start the feeds very slowly. Otherwise, there is something called as refeeding syndrome, which can worsen the child suddenly because of the sudden increase in the calories. Okay, so that for that purpose, we need to monitor the child. So if the child is severely malnourished and you are starting with the feeds, so better to admit the child and observe the child for signs and symptoms of refeeding syndrome. Okay, the type of caloric supplementation is based on the severity of malnutrition and underlying medical condition. The response to feeding depends on the specific diagnosis, medical treatment, and severity of the malnutrition. So, as per your diagnosis, whether it is psychosocial or whether it is a cardiac cause, whether it is a CNS cause, whether it is a respiratory cause, so the treatment changes according to the cause of the illness. If it is the cause is treatable, you have to start the treatment for the specific cause, and also supplement adequate calories. Only then the child will fall into the right track towards his attaining goal. Okay, target weight and target height. Apart from that, multivitamin supplementation should be given to all children with malnutrition to meet the recommended dietary allowance, because these children also have iron, zinc, vitamin D deficiency, as well as increased micronutrient demands with catch-up growth. So, as we know that iron deficiency is one of the commonest deficiencies especially in the Indian population, and approximately 60 to 70% of the pediatric populations are iron deficient, which causes the hemoglobin to be low, and which causes the growth faltering, uh, and also other micronutrients like vitamin D and zinc also. So we have to supplement with the micronutrients. Okay, apart from the calories also. Okay, and whenever these child are started with the being treated, and then again we start with the adequate calories, so there is a increased demand of these micronutrients because of the catch up growth. So And now the once the child starts to grow, so there's an increased demand of this micronutrient, so we have to supplement it along with the calories also. Therapy for psychosocial factors should be specific for the underlying issue, such as mental depression or insufficient fund for the food. If the child is from a low socioeconomic strata and there is a low availability of food, so we have to make arrangements, and social workers, we can involve the social workers and for the upliftment of the family and provide adequate nutrition to the child. Thank you very much. Today we have discussed about growth, development, and also the failure to thrive in a pediatric patient. And I hope you have understood the basic concepts about these topics. Thank you.